Hi, everyone. On today's podcast, we're going to talk with Dr. Nicole Rankins about the role of a hospitalist obstetrician and how families can prepare themselves to have a safe and fulfilling birth in a hospital setting. Today, I'm super excited to welcome Dr. Nicole Rankins to the Evidence-Based Birth podcast. Nicole is a wife, a mother to two girls, an obstetrician gynecologist, a podcast host, and an integrative health coach. Dr. Rankins did her residency at Duke University, and she currently lives in Richmond, Virginia. She also did a research fellowship at UNC Chapel Hill. Nicole currently practices in a community hospital in Virginia, and she loves helping women have a healthy birth and a healthy life. She started the All About Pregnancy and Birth podcast in 2019, and she offers online childbirth education at ncrcoaching.com. Nicole says her passion is helping women have a safe and fulfilling experience giving birth in the hospital. And as a hospitalist obstetrician, 99% of her work is on the labor and delivery unit. Welcome, Nicole, to the Evidence-Based Birth podcast.
Thank you so much for having me. I really appreciate the opportunity.
So how did you get into birth work?
Yeah, so this is a kind of a long story, so bear with me. Hopefully I won't be too long-winded. So my undergraduate majors were actually mathematics and mechanical engineering. And about halfway through that, I decided that I wanted to go to medical school. I had spent a year, I was in a dual degree program where I spent 3 years at one institution, Spelman College, and then 2 years at another institution, North Carolina A&T State University, where I got my engineering degree. And in between those, I studied abroad for a year in Kenya. And when I came back, I decided that I wanted to go to medical school. I can't say that there was one big thing that made me change my mind. I just kind of felt pulled towards it, for lack of a better way to put it. So decided to go to medical school. And when I got in medical school, I knew that I wanted to work with women. And I also knew that I wanted to do procedures. So I wanted to do things where I could use my hands. And I toyed between general surgery and OBGYN. And I ultimately decided to do OBGYN. I like general surgery, but I didn't like having males as patients. I had a few bad experiences of male patients hitting on me. And I was like, I'm going to go to OBGYN. So once I made the decision that I wanted to do OBGYN, at that point in medical school, I thought 100% that I was going to be a GYN oncologist. And a GYN oncologist is someone who takes care of women that have female cancers. So cervical cancer, ovarian cancer, uterine cancer is like the exact opposite of, labor and delivery. But then to change my mind again, decided that that's not what I wanted to do. In thinking about where I wanted to go, I knew that I didn't want to do private practice, and I kind of had a feeling that I wanted to stay in academics. So I decided to do a research fellowship. So after I finished my residency at Duke, I did a 2-year research fellowship at UNC Chapel Hill, where I got my Master of Public Health degree and set out on a course to be in academics and combine research with patient care. So I did that for about 7 years and across 2 institutions, and I just was not good at it. It did not work out well for me. It wasn't the best use of my talent. So did that for 7 years, and during that time, really didn't produce any research. So towards the end of that time, I was in a meeting with my department chair, and he said to me, I knew it wasn't going to be good because I hadn't been producing with research. And I thought it was going to be more of a discussion like, okay, you haven't done research, and so you're going to have to see more patients and do more clinical work, which I was prepared for. But during the course of that conversation, he said, and it was actually recommended that you be fired. And that just hit me in the chest because as someone who's used to being pretty high achieving, I would say, and getting things accomplished, that was like, whoa, where did this come from? And then to add insult to injury, now this is of course what he was saying. I can't verify this for sure, but the person who recommended considering firing me was actually a Black woman. So that added even more stress, and I got to do something different. I got to change. And I guess I should say for the listeners, I'm also a Black woman. So, so that's why it, kind of really hit me sort of hard. So I found myself in this position where I was like, I got to do something different. I got to look for another job, essentially. And my husband, Falcon, who's a wonderful, supportive, amazing husband, but he said, you know what, we're not moving again. We've moved twice for your job and the kids are settled. I have 2 girls. They are settled in school and we're, so we can't move again. We got to figure something out here where we are. So as fate, luck, or God would have it, I was at my OBGYN appointment. And my OBGYN was just asking me how things were going. And I was telling her about my job. She's like, there's an opening at my hospital for a hospitalist position. And long story short, I ended up taking the job and absolutely, positively loving it. So I went all the way from in the beginning to math and engineering, to thinking I was going to be a GYN cancer specialist, to thinking I was going to be in academics, to now being a hospitalist in a community hospital. And I absolutely love it for sure.
And for our listeners who don't understand the hospitalist role, can you explain what it is basically?
Yeah, so as a hospitalist, I work only in the hospital. So I don't have any office hours. I work only in the hospital. 99% of what I do is on labor and delivery and delivering babies. So I work an unusual schedule where I work night shifts. So I work 8 p.m. to 8 a.m., although I'm geared to change to a different schedule where I work 24-hour shifts, but it's shift work essentially. And you work on labor and delivery and you take care of whatever women who come to the hospital during your shift.
And how many shifts a week do you work?
It varies. So with the night shifts, I do 7 night shifts within 28 days. So I usually stack them together. So I may do 3 shifts at a time or 4 shifts at a time. And then I also do a couple day shifts and a couple weekend shifts, but roughly it's 3 or 4 shifts at a time.
And how many other physicians are doing this with you? Are there midwives as well, or is it just physicians doing the hospitalist?
Yeah, so we have 3 other full-time physicians, 2 part-time physicians in my program. And I also work at a hospital where we have certified nurse midwife hospitalists as well. So they work 24/7 in the hospital as well, and they work alongside us. So it's a similar model where they are not in the office. They are only there in the hospital, and they provide midwifery care to patients in labor.
So what are some of the benefits for patients for this model?
Yeah, so one of the big things is safety. You have a physician who is there in the hospital 24/7. So there's always someone available in case of an emergency. And also, as far as safety goes, you're not going to have a physician who is tired, who's been up all night the night before and having to continue to work. It allows for safer care and to have people who are well rested and ready to take care of you. It also helps eliminate some of the 5 o'clock push, so to speak. So you don't have this pressure that the reality is, people want to get home to their families if they can. So it reduces the chances of women undergoing cesarean delivery because physicians, trying to get home or trying to finish up a shift. We can smoothly transition care and make sure that women have all the options available to them and that their labor is not rushed.
Yes, there's been a lot of research on the hospitalist programs. Some people call it a laborist program. Mm-hmm. And I know that most of the results have been positive. Could you talk a little bit about the results from research?
Yeah, so for sure, research has shown that it can reduce the cesarean delivery rate when you have a hospitalist model. So for sure, implementation of a laborist model or hospitalist model has shown a reduction in cesarean delivery rates. It has shown a reduction in induction rates. In some studies, a reduction in preterm birth rates. And that is only improved when you do it with a collaborative midwifery model as well.
What about satisfaction? Because a lot of people I know choose their OB because they think I want to get to know them during pregnancy and then they'll be the one at my birth So how does satisfaction line up with the laborist model?
Yeah, so there's not a lot of data out there. There is one study that shows that patient satisfaction doesn't appear to be affected by having a laborist model. I think that's one of the really important things about laborists is that or hospitalists, is that we have to be very good about establishing quick rapport. And then also part of it is setting expectations. So the patients that I care for in the hospital, they know that there's a chance that there's going to be a hospitalist there, just like it may be another doctor who's on call. So I think as long as that preparation is done ahead of time in the office, then it ends up being fine.
Yeah, and I think most people don't realize, because a lot of people I talk with who say they chose the OB and they assume that their OB is going to be the one at the birth, but chances are you might get just whoever in that office happens to be on call.
Correct.
So you're kind of getting the same thing where you don't know who you're going to get. But the benefit with the laborist model is that you have a well-rested physician who knows they're going to be there for a certain number of hours and isn't going to rush your birth
Exactly.
in any way.
Exactly. Yep, for sure.
Tell me, I'm just curious, what are some memories that pop out at you from either medical school or residency with your OB rotation? I'm just curious if there's anything that just strikes you. When you look back on it, you think, wow, I can't believe I experienced that.
Yeah, I would say that a recent revelation that I've had, and I don't know if it's a memory or just a thought that struck me, is that we don't always ask explicit permission for doing things to women's bodies, something as simple as a cervical exam. Now, the unfortunate reality is that the specialty of OBGYN is kind of rooted in a system that's used to really exerting agency and control over what happens in a woman's body. And that goes all the way back to J. Marion Sims, who's considered the father of modern gynecology. And he did horrific experiments on slaves and women. And the reason that that was accepted is, and not looked down upon is because it was accepted during that time. And even in the 1920s to 50s, where women were given like twilight sleep and knocked out and unconscious for birth and strapped to beds and judicious use of forceps and episiotomy and all those kinds of things. And I don't know, it just kind of hit me within some of the work that I'm doing more in the community. And this notion that we don't always ask for explicit permission where we should. So not that anybody's mean or nasty, but just explicitly saying, is it okay if I check your cervix? Is it okay if I break your water? Is it okay if I strip your membranes? Those things are really important, and they may seem like small things, but they're not.
So what you're saying is you witnessed in your training that was kind of the culture, was just to do things.
Correct.
Without necessarily asking permission.
Correct.
And how are you trying to change that, or how have you changed? Because obviously that was your training, but from what I get the sense that you practice a lot differently than how you were trained.
Yeah. So that's actually one of the things that I'm sort of struggling with. I know that, and it's hard for me to say how I changed or look back and think about how I changed personally. I mean, I'll be honest. There was once a point in my early career where I would have rolled my eyes at a birth plan. I would have respected it, but I would have rolled my eyes at reading a birth plan. Whereas now I'm someone who has a free 1-hour webinar on how to make a birth plan.
Wow. So you really have gone from one extreme to the other.
Yeah. And I think just experience and maybe age a little bit, and just appreciating that women were not having good experiences. And ultimately, I really do want to make sure women have a good experience giving birth. So I'm kind of struggling a little bit with how to help facilitate that change within our profession. Obviously, change can happen. It happened to me. And there are good things. We know there are good things that we've done in OBGYN for sure. And there's definitely been progress. We're not obviously at the point where we're twilight sleeping women anymore, but there is some work to do.
What struggles are you or your community facing with regards to birth?
Yeah, so one thing that I see is that women can really arm themselves with lots of information. So there's definitely a lot more information available than there used to be. However, there's not as I see an appreciation for the fact that so much of your birth experience is influenced by the provider who's there at the time and the culture of the hospital where you give birth. So I'm really focused on helping women understand and giving them concrete questions to ask to really understand those things during pregnancy, because that's the time when you can shift and adjust if needed, whether that is change to a new provider, whether that is move to a new hospital, or whether you know going into your birth that you need to advocate for yourself. For example, if you go to a hospital and you're like, you don't want to walk into your birth and find out at that time that they don't even know what delayed cord clamping or support skin-to-skin contact. That's something you want to be prepared for ahead of time so you can adjust if needed.
So what you're saying is the main struggle you're facing is that families just aren't educated about the importance of the provider who's going to be there and the culture of the hospital where they're giving birth?
Yeah, for sure. I think they're educated about information and they know more about how labor should progress and they know more about what should happen, but they don't necessarily appreciate how the specific provider and hospital will play a big role in that.
Yeah. So what strategies or successes have you tried to help educate families and help prepare them to walk into different situations?
Yeah, so part of that is the work that I do now. So I got into some of this, what I call my side hustle, I guess, is even as a hospitalist, I realized that I kind of wanted to do more with interacting with women on helping them in a different way. And part of this stemmed from when I was in the office and in clinical practice. I often felt in some ways like I was a pap smear factory. Like I didn't have time to really talk to women and help them make changes in their lives. So that's how I got interested in health coaching. I knew a faculty member from my residency who had gotten into integrative medicine and integrative health coaching. And I talked to her and was like, this is something that I think maybe I could do and try. So I went back to Duke. They have an integrative health coaching program, and I became a certified health coach through that program. Sort of hung out my shingles with health coaching, and I had a whopping one health coaching client, and part of that was because of marketing, and you may be able to appreciate this marketing stuff, especially online, can be a challenge. And then it still wasn't exactly quite the right fit for what I wanted to do. So I took a step back and I took the things that I liked with health coaching, the holistic approach and taking into account how so many factors influence your health, your emotional health, your physical health, your environment, all those things, and then combining it with my work with delivering babies. And I came up with this idea of this online childbirth education class. It's called the Birth Preparation Course, and I'm very, very proud of it. And then other ways or strategies that I found successful are just meeting women where they are. And that was part of the reason why I decided to do an online format, is because that's where women are going for information today. And I know we poo-poo a lot of like Google searches and internet, but that's just the reality of where folks are looking for stuff. So we need to meet women where they are. So I do a lot of stuff posting on social media. I just started this podcast in January, which I absolutely love, all about pregnancy and birth, where I interview folks, I share birth stories, I talk about topics. And then also just getting out in the community, attending community events, listening to women. I feel like the issues that we have facing women in childbirth and helping improving pregnancy and birth outcomes aren't going to be resolved in the confines of doctors' offices and hospitals. We have to get out in the community. So just being open to connecting with different types of people who work in the birth space. We really need all hands on deck to make sure women have a great experience giving birth.
I really love how you're making a concerted effort to get out into the community, because I can only imagine that being a hospitalist, it might be frustrating sometimes to, people come in and things are already kind of going the way they're going to go. Like the time for preparation is over. Right. And so you get the situations you're going to get. So it must be nice to be able to do some preventative work and or health promotion work out in the community.
Yeah, I connected recently with a great organization in my area called Birth in Color, RVA, and it's a group of birth workers and doulas who are trying to help provide culturally competent or sensitive care in the community. And it's just been great to connect with doulas, social workers, lactation consultants, other midwives in the community who are all passionate about the same thing, making sure women have a great experience giving birth.
That sounds amazing. I'm sure
Yeah.
that they're thrilled that you're part of them, because it's not often that I see physicians reaching out to the community birth workers to say, how can I be involved in what you're doing? And so I think it's great. And I'm sure part of it is probably your schedule. The fact that you do work the hospitalist life gives you a bit more freedom.
Exactly.
Than a lot of physicians.
Yeah, and that's a really good point that you bring up. Like a lot of physicians just don't have the time to be able to get in the community. But as a hospitalist, I do. I have a lot more flexibility in my schedule, and I am able to get out and do these types of things more.
So, Nicole, do you have a question you'd like to ask me? How can I help you today?
Yeah, so I am curious what your experience is when you work with women. To me, now don't get me wrong, I encounter lots of great physicians who provide great care to women, but in a lot of ways, I feel like physicians are disconnected from the experiences that women have during pregnancy and birth. And what is your feel for that from the women you work with? And what suggestions do you have that we can improve the connections between physicians and patients and even other people who work in the birth space?
Well, I think that's a great question, kind of the $1 million question. I do think that is a core of a lot of the problems in our maternity healthcare system is compassion fatigue. So compassion fatigue is defined as, basically feeling indifferent. So just not really caring what somebody's thinking or feeling, because often it's a result of chronic stress or secondary trauma. But I do see that. I can't remember where I heard this quote. I'm sure it's a pretty famous quote, but a long time ago, I've heard like the opposite of love isn't hate, it's indifference. And I think what we need more of in any healthcare system is love and caring for one another, and that kind of humanized aspect to medicine is what is missing. And I see it in a lot of places, not just in maternity care, but in just various interactions I've had with the healthcare in general, ranging from dental care to gynecology care to pediatrics, is that there seems to be just an epidemic of compassion fatigue in that there's this indifference towards the patients who are seeking care. And that's a big problem. So I'm not sure if I know how to fix the problem globally or nationally in terms of helping the providers and the nurses and the staff who have compassion fatigue feel more compassion.
Right.
What I can do is I can work with families. And so we specifically in my childbirth classes work on how do we humanize the birth room? How do you get the nurses to, quote, fall in love with you? Because if you can get the nurses to fall in love with you, it doesn't matter if the physician doesn't like you. At least you'll have the nurses like backing you up. And same goes for if the nurses, you can't bring them on board with your plan, maybe you can get the physician or the resident to see you as a human being and go to bat for you and advocate for you. So that to me, just little things like teaching parents how to introduce themselves to the healthcare workers with a firm handshake and a smile and a how are you, and teach them how to make small talk with healthcare providers and staff. They're very simple things, but I've learned that in my many years now of interacting as a family member, as a nurse, that people skills are incredibly valuable. And I think people don't realize their importance. And of course, the problem is as a parent, especially if you're a first-time parent walking into a hospital to have your baby, for many of you, it's your very first time stepping foot as an inpatient into a hospital setting. And it can be very scary. And basic reaction to fear is withdrawal. So holding back, not smiling, not making conversation, not saying what you really think. And so I think rehearsing that is a big part of what I do with families, is rehearsing those basic people skills to try and warm up the room, so to speak, and get people to like engage with you and see you as a human being and not just that family in or that patient in room 309. Like, you want to be seen as your names, your people, your baby. So that's important to me. I do believe that, though. You raise a really good point. And I don't know if you've seen that in your career with the compassion fatigue and indifference towards individual patients.
Oh, sure. Absolutely. For sure. Unfortunately, it is something that I see. And that humanness is really the key, like you're saying. It's one of the things that I also tell women to do is to approach the interaction, start from a place of kindness and warmth. Sometimes I see that because women get like an impression, and some of it is warranted, that they're going to have a bad experience or not be listened to, they're going into the labor and delivery room like in a fight stance. And that is not the type of energy that you want for your birth, not just in the room, but your body doesn't work as well when you're approaching labor and birth from that sort of, I'm coming in with a fight. So sometimes you do need to take it there. But starting off, like you said, with that humanness and kindness, I think that's a really great thing that you're doing.
Yeah. Are there any other thoughts or questions that you have?
I don't want to say I'm obsessed, but I'm certainly like looking for ways of how physicians can connect with other people in the birth space. So I'm curious about what your interactions are like with physicians through your site or your work.
Oh my goodness. That's a great question. I think that I have a lot of physicians who I know follow evidence-based birth and subscribe to our emails and maybe even listen to the podcast, but they tend to be lurkers. I think partly because of their schedule. I have a sister who's a physician, and I know how stressful that lifestyle is. So every once in a while, they'll write me back from the emails we send out. I think that in many cases, the physicians that I know that I've met through evidence-based birth, I see them as almost like drowning. Like,
oh, interesting.
Yeah, I mean, that's the perception I get, is that they feel completely overwhelmed by their schedule and the pressures on them. And often, at least the ones who follow evidence-based birth, tend to also feel very alone because they're really on board with this stuff and they feel really passionate about it, but they might be seen as the troublemaker in their hospital. Right. Or, they might be actively being retaliated against. They just feel isolated because nobody else practices the way they do.
And again, that's what I was saying about the struggle of how we bring change from within our organization. So, because I really think there are more people than we realize who feel that way, but they do feel isolated.
And the schedule makes it even harder, because I've even toyed with the idea of hosting like a retreat for obstetricians and physicians who follow evidence-based birth to just really bring them together in person. And I struggled with like, oh, how would I even do that? Like, what would the logistics be? Like, how can they all get time off at the same time? It is one of the things that I'm hoping to do maybe later in 2019 is to just start hosting some focus groups, maybe even just one-on-one interviews to just pick the brains of the obstetricians and the physicians who follow evidence-based birth, either in a group like video chat or just one-on-one, just to kind of like tap into like what are their struggles and what do they see as solutions, because I think we need almost like a campaign to save the OBs, because the OBs who are really passionate about these topics, such as you, I think they need connection and support, and I'm not really sure the best way to do that given their crazy schedules. So you raise a really good point.
And I'm not sure about it either. So
yeah, do you have any ideas? Like, how often do you connect with other obstetricians that have similar, worldviews as you?
Yeah, so far I don't a lot. I'm starting to connect more with women or other physicians on social media through like Facebook groups and just following folks on social media. But it's really hard to find folks outside of my immediate circle who practice and subscribe to a similar philosophy as I do.
Yeah, so that is, for those of you listening, just stay posted. Once I get through some of the projects we're doing this spring, it is on my agenda to put a call out to try and just be able to talk with physicians, because I think it is key to creating change nationally and globally around the world, is supporting and figuring out how we can connect like-minded OBs who really support this type of care that we're talking about.
Yeah, for sure. For sure.
So, Nicole, how can people follow you on social media?
Yeah, so I am on Instagram, Facebook, Twitter, LinkedIn, all the sites at Dr. Nicole Rankins.
Okay, and your podcast is all about pregnancy and birth?
It's all about pregnancy and birth. I just released it in January. It's going very well. I absolutely love it. I interview experts. I talk about topics, and I try to find some out of the box folks. So I have a doula coming on soon. I have someone who talks about supplements in pregnancy. She's actually an OBGYN herself. Different models for postpartum care that link mom and baby's care together. Someone who talks about energy and your energy during your pregnancy and birth. So I'm open to lots of different things. And then also I do share birth stories. So I love to share women's birth stories because I believe women learn from the stories of other women. And you can find out about that on my website too, ncrcoaching.com. All of it is there.
Yeah, and encourage everybody to check out. You have a very friendly looking website, easy to navigate with all the podcasts right there at the top. So
thank you.
Yeah, thank you, Nicole, so much for joining us today.
Thank you so much for having me. I really appreciate it.